Good morning. I'm Brad Dickerson, Director of the Massachusetts General Hospital Frontotemporal Disorders Unit. I'm excited to be doing this presentation this morning, but a little sad that we're not in the same room that we're usually in at the Weston Waltham when we gather every year for the past decade or so. But we do what we can, and I'm thankful to all of you who are tuning in today. I'm also particularly thankful to Katie Brandt, of course, as always, for organizing this education day, and to Giro Studios for making it all possible to deliver to you through the wonders of technology. So I also like to start every presentation with an acknowledgement that I know things may be difficult right now, and we're here for you. And we want you to reach out to us if there's anything we can do to provide additional support. This painting is by one of our community members, a patient with FTD, and I often start talks with indications of the positivity that I think can still be carried through living with one of these illnesses. And whether it's painting or music or dance or humor or a variety of other expressions of joy and love, I think we all have to continue to encourage each other to share those and to maximize them as best as we can as we think through the details of these illnesses that we're working to try to develop treatments and eventually a cure for. I want to start by reminding you of our mission, or introducing it to those of you who may not have heard us talk about it before. The mission of the MGH FTD Unit is to improve understanding of frontotemporal dementia, primary progressive aphasia, posterior cortical atrophy, Young-Onset and atypical forms of Alzheimer's disease, amyotrophic lateral sclerosis with FTD, progressive supranuclear palsy, cortical basal degeneration, and related disorders, with the goals of finding a cure and providing comprehensive care for patients and families living with these conditions. Now, I know that's an alphabet soup of conditions, and I'm going to go through many of them, touching on the general principles. For some of them, we're going to offer separate modules to provide additional information for people living with those conditions. The work that we do can't be done without partnerships, and Katie Brandt leads a coalition of members of our community for Rare Disease Day every year that brings together members of the pharmaceutical industry, legislators, scientists, patients, and families living with a variety of types of rare diseases. And most of the conditions that we're talking about today are considered rare diseases, which are defined as affecting fewer than 200,000 Americans. The other partnerships that we value so much are those with our patients and families and our community. And with those, we can raise awareness, we can connect with each other, and we can potentially raise funding to support programs that are not otherwise paid for through insurance or through research project programs and federal grants. Thank you to everyone who participates in the variety of partnerships that we have tried to develop. The other important aspect is the power of stories. For each of you who is willing to share your story, that's yet one more voice that can reach many people through the power of the ways that these conditions affect us. And that's really what motivates our legislators and others to work harder to try to change some of the policies and help us get more funding for the work that we're doing. In part because of stories like this that have been told through the Alzheimer's Association Public Policy Forum and other forums, we've seen the federal research funding for Alzheimer's and related disorders quintuple over the past 5 years, which I think is the kind of long-term investment that we all know needs to happen for us to make the progress that we're all working so hard to make. I want to start by introducing the spectrum of neurodegenerative dementias, with the idea that pretty much every condition that we're going to talk about today proceeds following this type of rubric. People define these boundaries shown in blue on the screen somewhat arbitrarily, but essentially a normal person who is healthy may be considered in some cases to have preclinical disease when there's evidence that their brain systems are not functioning quite normally, or that there are biomarkers, which I'll talk about more later, that are consistent with one of these diseases in their brain or that are measurable in some way through their body, but otherwise they don't have symptoms. We then go into the prodromal stage where people are beginning to have some kind of symptoms affecting their cognition, mood, or behavior, but it's not yet very well defined what the diagnosis is. Sometimes during this phase, a clear diagnosis can be made, and we're working harder to be able to make a confident diagnosis at that stage of the game, when people's functions are largely independent at the moment. Then as people lose function, and I'll get into this a little bit more later, they're diagnosed with dementia, and that may be very mild, or it may be moderate or severe. And that often is a period of time that lasts for a decade or sometimes longer, sometimes shorter, but it varies by the person. And these categories are related to, in the yellow line here, we're showing the decline in people's cognition, behavior, or sensory motor abilities. For some people, one of these domains is affected more than others. And so that's part of the variability across people with these different illnesses. The reason the cognition is declining, or the mood and behavior or sensory motor abilities are changing, is because brain systems function is declining. And I'll talk more about this too. We have various ways of measuring this, mostly through neuroimaging technologies. And the reason that's happening is because neuropathology is accumulating, shown in green here, as a gradual development of changes in the brain that are causing the cells not to function properly, and are ultimately what causes them to die off and degenerate. These are called neurodegenerative dementias, and I'll talk more specifically about what those pathologies are later. What do we start with? We start with the diagnostic evaluation, and our goals for the diagnostic evaluation are to define the clinical illness, how has the person changed, and then to define the brain disease or disorder that is causing it. When we think about the clinical illness, we think about what the overall cognitive functional status is for this person. Do they have so-called subjective cognitive concern, where they have concerns and symptoms that are affecting them or that their care partner observes and can report on? But we can't tell that anything is wrong when we do our neurologic evaluation and our neuropsychological or cognitive testing. Then there's mild cognitive impairment, where a person and or their care partner are able to describe symptoms such as memory loss or difficulty with language or changes in executive skills and the ability to make decisions or carry out tasks, but the person is overall largely independent. And we can measure changes in a person's abilities to perform tasks on the neurologic exam or cognitive testing in the office or on neuropsychological evaluation. And I'll get more into this in a moment. And then there's dementia. So that's the overall cognitive functional status, and I'll talk more about that in a little bit. And then there's the next question is there a recognizable cognitive behavioral syndrome? These are typically syndromes that we have names for, like primary progressive aphasia, that is a shorthand for describing the particular symptoms that a person has. And Megan Quimby will talk more about this shortly. There are also conditions that we just label with a term, like amnesic and dysexecutive syndrome, and I'll talk more about that in a little bit as well. We're moving as a field away from a time when we used to talk about the diseases as the overall name of what the person has. We're now moving toward talking about the syndrome and the disease that causes it. Then the next question is, are there important accompanying clinical features? Those may be changes in a person's motor function, like coordination or walking or hand movement or eye movements or swallowing. They may be psychiatric symptoms. They may be medical conditions that accompany the process, such as a particular type of sleep disorder. So that's really what we spend a lot of time trying to figure out when we're evaluating people. Then what we want to know is, what's the brain disease or disorder that is causing the changes in the person's abilities? And this is where laboratory imaging or other kinds of tests can give us so-called biomarkers that are markers of the pathology processes that are going on in the body that we think may be the cause or a potential contributor to the problems. And sometimes these lead us to conclude that we are very confident that there's a specific brain disease that's the underlying cause. Other times it's not so clear. And then ultimately we want to use all of this information to try to develop a comprehensive treatment and care plan tailored to the person, but based as much as possible on evidence. So here's our schematic for how we operationalize these 3 steps. Step 1, cognitive functional status. Step 2, cognitive behavioral syndrome. Step 3, neurodegenerative brain disease, if that's what's going on. I'll talk more about what other alternatives are in a moment. So when we interview the patient and when we interview the informant or care partner, we're asking in as structured a way as we can for people to describe the symptoms that they're experiencing in their day-to-day life and how those affect them. When we evaluate people in the office or in remote circumstances over the phone or through the computer, we're trying to measure signs. That is, what can we measure on our tests that are indicators that a person may have a problem performing a certain kind of task, such as a memory task or a language task. We may not know where the person started, but we can infer based on their former occupation or other activities in their life that they should likely have been able to perform at a level higher than this. And then we can use that information to track them over time in terms of changes in their ability to perform on different kinds of tests. And then in terms of step 3, the neurodegenerative or other brain disease, here we're talking about neuroimaging, such as brain MRI to measure brain structure, PET scan or EEG or SPECT scan to measure brain function in some cases. And then we're increasingly able to measure markers of molecular brain pathology through either different specialized types of PET scans that I'll talk about or through spinal fluid. For the most part, this is only available right now for markers of Alzheimer's disease, but the field is working very hard to try to develop markers measurable through PET scans or spinal fluid of different other neurodegenerative diseases that I'll talk about shortly. Let me unpack overall cognitive functional status for you a little bit. This is defined by the loss of independent functioning due to cognitive or behavioral impairment. This is really meant to represent something that is a change from a person's previous level of functioning. It doesn't matter when in life it happens, except that it should represent a decline from a person's previous level of function when it comes to these different types of diseases. And this is a schematic to illustrate the full range of this spectrum that I was alluding to earlier, where people may be cognitively normal, but may be either at risk for or beginning to show signs of abnormalities on brain scans or other measures. They may be beginning to notice changes in their performance on routine tasks at home in the subjective cognitive decline category, but we can't measure changes when we evaluate them. Or they may be in the mild cognitive impairment stage where we can measure changes in people's ability in terms of their problems performing tests of the sort I was mentioning earlier, but they're largely independent in their day-to-day life. And then we move through the different stages of dementia, with the idea being that when a person is diagnosed newly with dementia, they're typically at a very mild or mild stage of dementia. It usually represents a loss of independent functioning, but it may be the loss of a job, for example, while they are still able to retain many independent functions in their home and community life. So this is part of what we do when we try to characterize the types of impairment in people's function due to cognitive or behavioral change. When we think about the levels of independent function, we think about advanced activities of daily living as listed here, and these are largely some of the more complex, cognitively demanding tasks that people do in their job or in the community or at home. And then we have instrumental activities of daily living, which tend to be reasonably complex activities, but often not as challenging cognitively as the ones under advanced activities of daily living. And then we finally get to basic activities of daily living, which include eating, dressing, grooming, and or dental care, physical ambulation, walking, bathing, and toileting. These levels of independent function or their loss are really what define the different levels of dementia. Why is it important to establish cognitive functional status? A major goal of care planning for people with cognitive impairment or dementia is to help people maximize their independence while maintaining safety. And that can be a fine line that we have to navigate and reevaluate on a regular basis. For some people, this is fairly straightforward to navigate, and for others, it's incredibly complex and requires a multidisciplinary care team to try to help navigate that landscape. It also allows us to think about the adaptations and supports that may be critical or may need to be reevaluated on a regular basis to help the person function as independently as possible. Many patients with dementia lack insight, the understanding and appreciation of their illness, and so this can be a real risk and represent a vulnerability when it comes to situations where patients may get taken advantage of. And that often leads to concerns about privacy, as well as a number of other issues that are important to address right up front. And finally, creative approaches are often necessary to implement care plans, in part related to the patient's insight and their overall cognitive functional status. This is a schematic of our approach to diagnosis in clinical practice. Starting with the clinical status, which, as I mentioned earlier, is informed by symptoms and signs. Let's talk some more about this. This is the illness that the person is living with if we're able to make such a diagnosis. The dementias really represent a confluence of the worlds of neurology and psychiatry and psychology. Some of the terms that we use come from one field and some come from the other field. One of the master guidance documents for the diagnosis of some of these conditions coming from the mental health world is called the DSM, the Diagnostic and Statistical Manual. And we're now at the 5th edition. And this is how it defines the neurocognitive disorders, as they're called by that document. Major neurocognitive disorder, which is synonymous with dementia, and mild neurocognitive disorder, which is synonymous with mild cognitive impairment. As I was mentioning earlier, these are really representing the overall cognitive functional status, with major neurocognitive disorder or dementia referring to a situation where the acquired problem has gotten to the point where it's interfering with a person's ability to be independent in their day-to-day life in the ways they used to be. Whereas mild neurocognitive disorder or mild cognitive impairment, as the neurology world often refers to it, is a milder stage where the person may have symptoms and signs, like I was mentioning before, but is not yet at the point where they need substantial help in carrying out their day-to-day activities. They may have developed some strategies that help them compensate, but they're still largely independent. With regard to the domains of cognitive function and behavior, the DSM-5 defines 6 key domains that are largely well accepted across the fields of neurology and psychiatry. Complex attention, the ability to pay attention to and process multiple types of stimuli. Executive function, the ability to plan, organize, and complete tasks or projects. Learning and memory, the ability to learn information and remember it later. Perceptual motor skills, which is the identification of complex visual information or the recognition of faces, or complex motor tasks that are learned. Then there's language, and then social cognition, the ability to behave appropriately under the current social circumstances. The domains of cognitive function are controlled by major brain networks, and this is a field of complex cognitive neuroscience that we won't get into detail on today, but just to touch on a few briefly, with the purple in the back being complex vision, the green in the outside and toward the front being parts of the attention network, the orange here in the frontal lobes being parts of the executive function network, and the brick red color here in the frontal, parietal, and temporal lobes, as I'm showing with my mouse, being part of the language network. So we've got these standard brain images that show the frontal lobes here, the parietal lobes here, the occipital lobes here, and the temporal lobes here. And they're showing the left side of the brain viewed from the outside and the left side of the brain viewed from the inside. And the same thing with the right outside and the right inside. I'll show other brain images that depict these kinds of views, but in general, keep in mind that there's a complex array of real estate here that really determines what functions are going to be affected if a person has damage of any sort in that particular system in the brain. So when we think about the major clinical syndromes, the cognitive behavioral syndromes that people can be diagnosed with when they have dementia or mild cognitive impairment, there are problems with memory, and we call that amnesia. There are problems with executive function. We call that executive dysfunction. There are problems with language. We call that aphasia. There are problems with visuospatial function. We often call that agnosia or visual agnosia. There are problems with personality and social or emotional behavior. We often refer to that under the larger umbrella of mood or behavioral symptoms, but there are specific properties of those characteristics that we can label, such as loss of empathy, disinhibition, or loss of filter, and so forth. Those really relate to problems in relating to others or in conducting oneself, such as having the motivation to do things, or if that is lost, the person has apathy, having the ability to be emotionally expressive or to regulate your emotions, or having problems with compulsive behavior, including things like inappropriate eating or drinking behavior. And then we've got more complex motor function, which we refer to as apraxia. So these are some of the neurologic or psychiatric terms that you may hear when people are being described as having a particular set of problems in their symptoms and signs. So in terms of these mappings, when we go from the domain of cognitive function to the impairment, we're often talking about just the inversion of the word. So attention may be called inattentive syndrome or attention deficit syndrome. For the most part, this is a very different thing when it's acquired as part of a dementia than what you might typically think of as attention deficit hyperactivity syndrome in kids. Then there's executive function, which is often referred to as the dysexecutive syndrome, language, the aphasic syndrome, memory, the amnesic syndrome, visual cognition, the agnostic or spatial syndrome, social personality, the behavioral syndrome, and mood, the affective syndrome, sensory motor, apraxic, and so forth. So when there's a single domain, that's typically referred to as primary, such as the primary aphasic syndrome. And if it's progressive, we call it primary progressive aphasia, as Megan Quimby will talk about, or multi-domain, when there are multiple domains that are involved and it's a little bit more difficult to give a specific label to. These terms are often confusing to not only patients and care partners, but also other professionals, and are often used differently by different people. And so the field is working hard to try to develop a more consistent nomenclature for the use of these terms. Let's now get into FTD more specifically. And as I mentioned before, I'm going to touch on the major syndromes in frontotemporal dementia, and we'll have separate modules on some of the other syndromes that we discuss and that we work with in terms of the FTD unit's mission. How common is FTD? It's thought to be the third most common neurodegenerative dementia after Alzheimer's disease and dementia with Lewy bodies, probably representing somewhere between 5 and 15% of everyone living with dementia. It's estimated to affect somewhere between 50 and 150,000 Americans, although we really have pretty sparse data when it comes to the epidemiology of FTD. A lot of it's estimations and guesswork. It's typically young onset, often affecting people in their 50s or 60s. It's thought to be the most common young onset dementia. Cases have been reported with onset as young as in the 20s and as old as in their 80s. Ourselves at the FTD unit, we've seen people as young as 27 and as old as 86 when they develop their symptoms. Up to 1/3 of cases may have a positive family history, although it's probably only about 10 to 15% who have a clearly genetic cause of their FTD. And we'll talk more about that later. The diagnostic criteria for FTD were revised in 2011 with new definitions of behavioral variant FTD and primary progressive aphasia. Generally speaking, behavioral variant FTD is a syndrome of social, emotional, and executive dysfunction. This includes problems with loss of filter, which we refer to as disinhibition, loss of motivation, which we refer to as apathy, loss of normal emotional connectedness with loved ones or others, which we call loss of sympathy or empathy. And those are often very difficult to sort out from psychiatric illnesses, as are repetitive or compulsive or ritualistic behaviors, changes in eating or drinking, and executive dysfunction when it comes to not being able to get things done. Not everyone has all of those. Some people have a more disinhibited type of behavioral variant FTD. Other people have a more apathetic type of behavioral variant FTD. So it's like many of these conditions where you get the label, but it doesn't tell you everything you need to know about exactly how a person is affected. Then there are the progressive aphasias that Megan Quimby will go into, and we recognize 3 major types that she'll describe in detail: the non-fluent or agrammatic variant, the semantic variant, and the logopenic variant. The progression of FTD is as follows. It often starts out distinctly as one of these variants, although not everyone follows the textbook, and we sometimes have people that present with a mixture of these symptoms or with symptoms that look more like the memory loss that you see in patients with Alzheimer's disease. As it progresses, it often progresses to involve other domains. So people with progressive aphasia may start to have some other types of cognitive or behavioral symptoms. People with behavioral variant FTD may start to have some language or memory symptoms as it progresses. And this all depends on the type and the location of the changes in the brain, going back to my slide earlier about the major brain systems. We also sometimes see changes in movement, which is a topic of the last International FTD conference, and is often talked about in the worlds of intersection between the FTD community and the ALS community, or the FTD community and the Parkinson's community, where some of the symptoms may look like one of these other illnesses, but they're most likely part of the condition that the person had to begin with that are just being manifest at a later stage. These include incoordination, slowing of movements, stiffness of movements, changes in walking or falls, changes in eye movements, and impaired swallowing. Overall, with FTD, the survival is wide-ranging, sometimes going from diagnosis to death in as few as 2 or 3 years, sometimes taking as long as 20 years after the onset of symptoms. The average, though, is generally from 7 to 12 years, somewhere on the order of a decade or a little less, with new findings coming out on this all the time. And this depends on how early a diagnosis is made, which, as many of you know, can often take some number of years to obtain. Current treatment of FTD is limited, but I always say there are treatments for FTD. The problem is that the treatments don't slow the disease progression, they don't cure it. We're working on some of these types of treatments with clinical trials and other medications in development leading toward trials, and Dr. McGinnis will talk about that during his lecture in a little bit. We don't have any proven medicines to treat symptoms that are FDA approved, but there are several studies that have shown benefits of certain types of antidepressant medications or other medications for managing symptoms. Some of the existing medicines may be helpful for managing various symptoms, and those include medicines used to treat Alzheimer's disease, stimulants, antipsychotic medications, anti-seizure medications, and, as I mentioned earlier, antidepressants. The best type of treatment, though, in general, is with a comprehensive interdisciplinary team approach, because a lot of the treatment involves education, psychosocial support, and behavioral strategies, as well as potentially modifying living conditions. This is often carried out by a team of specialists, as listed here. Sometimes occupational, physical, or cognitive therapists are involved. The Association for FTD or Alzheimer's Association or other organizations can often provide support as well, and community care programs are a critical component, which Katie Brandt will talk more about. The diagnostic criteria for PPA will be reviewed by Megan Quimby shortly. So why is the clinical syndrome important? The clinical syndrome label helps people have a word they can use, or a set of words they can use to label their experience and give shorthand to what's going on. So PPA, for example, primary progressive aphasia, is a label that quickly summarizes to others living with the condition or other healthcare professionals who are aware of the condition what a person's major symptoms are. And sometimes we often append to that label with or without mood or motor symptoms to describe the additional nuances that healthcare providers or others may need to know. This label also helps identify symptoms for therapy of various sorts, and those may be medications such as amnesia, often at least being considered for treatment with donepezil or other cholinesterase inhibitors, or with memory cues and strategies, whereas aphasia would require a very different type of treatment strategy with speech-language therapy or other supports for that type of problem. The label also captures some elements of care planning and support needs. For example, with behavioral variant frontotemporal dementia, there's often an important element of safety and structured programs that are important from the very beginning. The label also connects them with appropriate community resources and helps identify people for potential recruitment for clinical trials or other kinds of studies of interventions or other projects that are going on. Let me next review the diseases that lead to these symptoms in our approach to diagnosis. When we think about the diseases, we think about changes in brain anatomy, brain function, and all of this is arising as a result of brain pathology. Traditionally, we used to just be able to see these kinds of things under the microscope, but increasingly we're developing, as I mentioned earlier, biomarkers of things like amyloid plaques and tau-related tangles, the pathologies of Alzheimer's disease. Let me just touch on the spectrum of diseases and disorders that can cause cognitive impairment and dementia, with the idea that this is part of what we do tests to try to determine. In the left-hand column is the list of neurodegenerative diseases, such as Alzheimer's disease, that is marked by beta amyloid plaques and tau neurofibrillary tangles. Frontotemporal lobar degeneration, which is the term used to describe the pathology of frontotemporal dementia. And so frontotemporal lobar degeneration may be related to tau pathology, and there are several types of primary tau pathology without amyloid plaques that's different from the tau pathology that you see in Alzheimer's. Or the other major type is frontotemporal lobar degeneration with TDP43 inclusions in the cells. Together, these make up probably 90% or so of cases with about half of each. And then there are other much rarer forms of frontotemporal lobar degeneration pathology. And then there's Lewy body disease, which is what we see in Lewy body dementia or Parkinson's. And this is alpha-synuclein, which is a completely different protein than the others mentioned above. And then there's ALS, also known as Lou Gehrig's disease. And this also has TDP43 in it, which is thought to be very similar to the TDP43 that's in frontotemporal lobar degeneration. It's the same protein, but the abnormalities may be slightly different. And the location of those abnormal protein deposits in the brain are in the motor systems instead of in the frontal lobes or temporal lobes. And then there are less common neurodegenerative diseases that have their own specific proteins that build up in the brain. In the right-hand column is the list of other conditions, starting with the most common, which is cerebrovascular disease, which can be stroke or can be so-called small vessel ischemic disease, which is essentially the modern view of hardening of the arteries. And in general, if you look at people over the age of 70, 75 that have dementia, the most common thing we see is a combination of Alzheimer's and cerebrovascular disease, statistically, in terms of what's wrong with the brain. There are many other medical and other neurological conditions that we also need to keep in mind as either causing or possibly contributing to a person's symptoms. We want to try to rule those out or optimize them as best as we can. When we think about what's going on in the brain in terms of frontotemporal lobar degeneration, this postmortem brain sample shows the striking shrinkage that can be seen in the frontal or temporal lobes. And this was originally called Pick's disease back when Professor Arnold Pick first described it in the late 1800s, with the observation that there's a remarkable preservation of the back part of the brain, the occipital lobes and other parts of the brain that control vision and motor function, which is why for many patients, there are certain functions that they're still able to do with remarkable abilities. When you look under the microscope, you can see that the different cells in the layers of the cortex, the cerebral cortex that is the outer ribbon of the brain, where a lot of our thinking abilities come from, is compromised. And so the normal cells and their connections is what we're able to look at under the microscope and see in these pathology slides that in between these arrows, there are a lot of white spots, which are basically areas where there used to be brain cells and connections between brain cells that no longer have anything in them. And so the cells have been lost, they've degenerated and are no longer present. And then there are also other markers that you can see under the microscope that show the abnormal accumulation of forms of proteins that should not be accumulating inside of brain cells. These are normal proteins that have important functions, but they shouldn't be accumulated like that, damaging the inner workings of the brain cells. So the pathology is located in the frontal and temporal lobes and some subcortical structures that may influence things like sleep and even sometimes blood pressure regulation. And the types, as I mentioned earlier, are tau and TDP43 and some less common ones. Sometimes we also see people with Alzheimer pathologies and Lewy body pathologies co-occurring with FTD, but that's relatively uncommon, particularly in younger people. These proteins are normal and have important functions, but in these diseases, they become twisted, tangled, clumped within cells, clog up the machinery of the cell, and damage the inner workings of the cell. And for some reason, this only occurs in particular types of cells in certain brain regions, and we don't yet understand this holy grail question for why those areas and even those cell types are specifically affected. Sometimes, rarely, as I mentioned earlier, this is because of a single genetic mutation, but most of the time we don't know what the cause is. And so we know that people develop these conditions often, as we say, sporadically for no known reason, and we really don't understand why at this point. There's a mapping between the neurodegenerative clinical syndromes and the neurodegenerative pathologies that goes essentially like this. When the main problem is memory and it looks like a typical Alzheimer-like presentation of gradually progressive memory loss, that's usually associated 80 to 85% of the time with Alzheimer's pathology. When there's a gradual development of primary progressive aphasia, that could be one of the types of FTLD, or it could be Alzheimer's. When it's vision, which is called posterior cortical atrophy, that's usually Alzheimer's disease. When it's social and emotional behavioral with behavioral variant FTD, it's usually one of the frontotemporal lobar degeneration pathologies, but sometimes it can turn out to be AD or even Lewy body disease. And we'll have other modules on some of the less common conditions to talk more about those as well. Now let's come back to the role of biomarkers in the diagnostic evaluation of people with cognitive impairment or dementia, focusing on imaging. There's a lot of variability, as I mentioned earlier, with some patients having problems more in the frontal lobes, some patients having problems more in the temporal lobes, and those lead to the different phenotypes, the different syndromes that people have when they have these conditions. And you can often see that on MRI scans. Sometimes we need glucose PET scans, or so-called FDG PET, to see that. And this is, like I was showing before, a view of the outside of the right half of the brain, a view of the outside of the left half of the brain, and some views of the front, back, top, bottom, and the inside of the right and the inside of the left half of the brain. And the blue colors here indicate reduced function. So in Alzheimer's, you tend to have the back of the brain in the parietal and temporal lobes toward the back where the problem is. In typical frontotemporal dementia, you tend to have much more of a problem in the front of the brain, frontal or temporal lobes. But there are some patients where you can see unusual patterns with both frontal and parietal and temporal lobes affected, and often a very asymmetric presentation. And that's where we need other methods to try to tell us, is this Alzheimer's or FTD or something else? And then there are other patients where it's much milder, and even though this looks like it could be a form of Alzheimer's, it's pretty subtle, but it is more in the back of the brain than it is in the front, but it's only on one side, really. So this is often where we need additional help to make a more confident diagnosis. So some of the research we're doing is to try to get additional information out of MRIs beyond what you can get by just looking at them, by using computerized methods to measure things like the thickness of the cortex. So this is just an illustration where you can actually measure how thick the cortex is in millimeters. It varies between about 2 and 3.5 to 4 millimeters, so it's pretty small. But you can see when you look at an MRI scan, when there's shrinkage like there is in this person with semantic variant PPA, you really are hard pressed to see much of the cortical gray matter over here on this side. Whereas on this side, you can see a nice clear ribbon of gray matter that's pretty thick. So what the computer can do with some advanced methods is quantify that and show us where there is shrinkage. And we were happy in one of our studies to partner with Northwestern and be able to show across MGH and Northwestern, we get a highly consistent pattern of shrinkage in the semantic variant of PPA in the temporal lobe. And we get a highly consistent pattern of shrinkage in the non-fluent agrammatic variant in the frontal lobe. And we also get a highly consistent, although not quite as clear, pattern of shrinkage in the back of the temporal lobe and the parietal lobe in people with the logopenic variant PPA, which Megan will talk about shortly. So these imaging biomarkers are useful in clinical care to help with an earlier and more confident diagnosis, and are helpful in research in terms of thinking about inclusion criteria or outcome measures for clinical trials, as Dr. McGinnis will talk about. We still need to do a lot of research to compare them to each other and to see how useful they may be for prediction or monitoring, which is part of what some of the observational and natural history biomarker studies are that we're asking you to participate in. Finally, we have the molecular biomarkers that you can measure either in the spinal fluid or with PET scans, with amyloid PET being the first one that came out in 2004 to measure plaques in Alzheimer's disease, and tau PET coming out in 2013, which so far has been mostly useful for Alzheimer's type of tau pathology, but we're working really hard to try to make it be more useful for the frontotemporal lobar degeneration type of tau pathology. Why are these relationships present? We really don't know why the pathological forms of these proteins tend to start causing problems in specific brain regions. And we also don't know how they spread very well, but the thinking is so far that they spread through the normal connections that make up the circuits of the brain. And I'll come back to that in a moment. So why is identifying the underlying brain disease important? It identifies potential targets for treatment, such as if the pathology is likely AD, then maybe the combination therapy can be useful. That's proven to work. One form of PPA that's often due to AD pathology, called the logopenic variant, has been shown to have a deficit of this neurotransmitter called acetylcholine, which we have drugs to try to improve. And we hope to develop future disease-modifying therapies for all of these other conditions as well, and there are clinical trials for some of them going on right now. This information also is useful for more personalized prognostic planning, for discussions of possible genetic risks, and to connect people with research, including clinical trials. So I want to close by talking a little bit as I conclude about our mission in more detail. We aim to provide comprehensive clinical care starting with diagnostic evaluation, involving a multidisciplinary team, to try to then move toward comprehensive treatment and continuity of care with the overall goal of managing symptoms and maximizing overall function in daily life using a variety of approaches. We want to provide social support and assistance in connecting patients and families with community resources, as Katie will talk about, and to provide genetic counseling for patients and families, as well as autopsy services for ultimate pathologic diagnosis. Some of what we do in maximizing symptoms aims to promote resilience and to connect people with studies that may provide meaning to them as they navigate their journey with the illness. And Dr. Wong will talk more about that in a little bit. We also have an education mission to train and educate the next generation, and we've trained clinician researchers as specialists in this field or with specialized skills, including speech pathologists, neurologists, psychiatrists, internists, and people specializing in psychology and neuroscience research, as well as many trainees who are residents or medical students, graduate students, and others. We have a course coming up that we do annually called the Dementia, a Comprehensive Update. It's a 3.5-day course for clinicians, physicians, psychologists, nurses and social workers, and others. This year's course is live stream only, but it's still happening, and we hope it brings the latest and greatest in cutting edge knowledge about these conditions to a large community. We also have a robust research mission to better develop methods for assessing the presence and severity of symptoms in daily life, to develop better instruments to measure the performance on the tests of the domains that I talked about earlier, and to enhance advanced imaging techniques for measuring brain structure, function, and pathology, with the ultimate goal of improving accuracy of earlier diagnosis, prediction of progression, monitoring of progression, and rehabilitative strategies to try to improve function. And Dr. Wong will talk more about this in a moment. A couple brief examples as I reach the end of my talk. Tau PET imaging is an area that we're emphasizing with the idea that at least in some patients, the location of the signal that suggests tau pathology is right where the shrinkage is in the brain. And so we think there's a strong relationship, at least in some patients, between the tau pathology accumulating in the brain and the neurodegeneration and loss of brain cells. Primary progressive aphasia offers a particularly interesting condition where the normal language network, as shown here from a functional MRI scan of a healthy group of people, showing where their brain activates when they're reading sentences, is very similar to the areas when you put all the patients with PPA that I was mentioning earlier and that Megan will talk about into a single group. You can see that almost that entire real estate is affected in PPA, but not much else. A lot of the right hemisphere and a lot of the other parts of the brain, including visual parts of the brain, are really not affected. And what it turns out, at least in some cases, to be is that the tau pathology that we now have the ability to measure, at least in some forms of tau, is right at the intersection between these. And it looks like there's something about tau that happens to affect a certain network and then probably spreads through the connections of that network, as I was mentioning earlier, and which is the subject of a couple of studies that we're doing right now. And finally, we can, in some cases, take skin biopsies and use the DNA from a particular person with a genetic abnormality, if they have such a condition, and model that by repurposing those cells into stem cells that can then be grown into neurons in the lab in cell culture. And working with members of the Center for Genomic Medicine, we've developed methods for trying to use those systems to evaluate, for example, compounds that may be able to reduce pathologic forms of tau as they begin to accumulate within the brain cells, working with Diane Lucenti and Stephen Haggerty and Katerina Silva and others in that center at MGH. Finally, we couldn't do this without the partnerships of our consortia. We're members of a number of national and international consortia. This is a map of the All FTD consortium that developed out of the previous consortium from the Lefties and Artful Studies. And what we hope to do with all of these is be able to map all of the symptoms, signs, and pathologies to a greater degree so that when we're able to start giving people interventions, we can hopefully see their effects. And so as one example of an intervention, Dr. McGinnis will talk about drugs, but there is a major study going on being sponsored by the Alzheimer's Association aiming to evaluate the effects of a healthy lifestyle, exercise, diet, and so forth in people that had not previously adhered to such a lifestyle. So we're not just talking about drug medications, we're talking about things that may be more lifestyle interventions or other kinds of interventions. What we hope to be able to do is see the effects of those interventions as it relates to slowing down the decline of people's cognitive dysfunction. I couldn't do all this work without an amazing team. I want to thank my team for their dedication, including in the time of COVID, to continuing to fight the good fight against these diseases and put all of your interests foremost in our minds as we try to conquer these terrible diseases. Thank you very much for your attention. I hope you all stay well and stay safe and stay connected with each other and with us as best as you can during these difficult times. Thank you.